Sarah. My background, just briefly, my PhD is actually in neurobiology and anatomy. I studied the neuroinflammation mechanisms in Alzheimer's disease for about 10 years or so, back east at the University of Rochester and then at Harvard, at the Brigham and Women's Hospital. We did sort of neurodevelopment meets aging in the brain, which was really interesting studies. But my passion was always in public health. So after that, I went and did a master's of public health at Boston University. And then I taught there in an adjunct role for a number of years while simultaneously moving into a health policy and management consulting world. So I've done a lot of health systems improvement efforts, largely in the Northeast. We moved to Spokane, Washington in 2019. And since being here, I did still work virtually on the East, but I've got some projects in California and Oregon and starting to move into Washington. My role at Gonzaga University and the University of Washington just started about 6 months ago. So I am now fully focused in Spokane, Washington, but I also am still doing a little bit of consulting work on the side in terms of, I call it sort of health system transformation efforts, if you will. I always did wonder where the neuroscience and public health world would come together, and mental health and addiction studies are going to be a part of my scholarly efforts here at Gonzaga, and I've started really doing a lot of research and work in the area of psychedelic science. So I have zero interest in really working in like recreational psychedelic use. That's for the lawyers and the other folks to decide. But as a scientist, I have found it really compelling to look at the research. So what I hope to do today is to demystify some of the current knowledge and findings on the use of psychedelics in psychotherapy, for mental health, for addiction, where the current regulations are, and what we expect in the future. I also am open to questions. I'll keep the chat open and try and pay attention to it, but you can also interrupt me at any point. Questions while I'm getting my screen shared? Okay. Can we see this?
I can.
You're not in presenter view from what we can see.
Oh, how about now? Does that look like presenter view?
No, I'm still seeing the small slides on the side.
So interesting. Okay, let me try one more thing. I have way too many screens. I probably should just use one screen. And if you all have that. Okay, does that look better?
Yes.
Excellent, thank you. Okay, all right, so I'll start with an introduction, sort of overview. I'll give you a little bit of the history of psychedelics, the substances themselves. And then that overview I'm going to give you with a little bit of the mechanisms of action and kind of just real high level changes in the brain chemistry and structure and function. And then I'll move into common psychedelic agents. For each one, I'm not going to go through every one individually, but the ones that are really important in the US today and for addiction and for mental health. And then we'll talk briefly about some challenges and considerations, future directions, and then hopefully we'll have time for questions at the end. My goal is to have this go no more than about 30 minutes. Okay, so as an introduction, something is psychedelic commonly when it has hallucinatory effects at certain doses. And that happens because most of them act as agonists on the 5-HT2A receptor. So 5-HT is another way to say serotonin. So you might see them used interchangeably. So serotonin 2A receptors, there's lots of different serotonin receptors. 2A receptors are the ones when bound to cause the visual hallucinations. They're very well concentrated in your visual cortex, in your occipital lobe back here, and lots of other places in the brain, actually. Most of the psychedelics use that receptor to exert a lot of their effects, but many of them use a lot of other receptors. So we'll get into that in a minute. They do produce changes in perception, in mood, and in cognitive processes. We'll walk through that. And they can affect all of the senses. They can alter thinking. They can alter the way that people perceive time. They can alter emotions. And again, those are also usually with a dose-dependent effect. So the second question I usually get, besides what are they, is are they safe? So generally speaking, they're considered physiologically safe. There are a number of studies showing this. There are clinical trials that have worked on safety first, and now they've moved into other phases. There are a few notable exceptions that we'll get into, specifically with things like ibogaine. They don't lead to dependence or addiction. That's another common question I get, is if you're going to treat addiction with a psychedelic, do you then have another addiction problem on your hands? You don't actually. Yes, do you have a question, Jim?
Yeah, and I'm sorry to do that so early, but
Just do.
are you talking, I'm assuming that you're talking about they are safe when used the way that you're talking about in a medical, but are you also including kind of street use of these?
No, I'm not. Actually,
Yeah.
I don't feel qualified to make that statement. There are folks that will tell you they're absolutely safe recreationally. There are a lot of regulations that are working on that. Again, I'm really, for this purposes of this talk and for my work, speaking clinically safe, because we have a lot of studies showing that they can be used safely in a clinical setting. We'll talk a little bit more about that. Thanks for that clarification. Yeah. So one thing to think about, though, in terms of safety is, I do get a lot of questions about this. There's a lot of stigma based on misinformation and the lasting impact of the war on drugs where psychedelics are concerned. And so combing through that and finding out what's real and what's not in terms of safety, in terms of, lots of different things. But there were a few, negative instances back in the 60s and 70s that caused what we have today, or what we had, which was sort of a 40-year shutdown on the use and study of any of these agents that are real and that are important. And so whenever I do talk about, or I show research associated with these agents, it needs to be made clear that yes, there can be instances where there's a negative effect or a maladaptive situation. It's typically rare and it's typically an exception. However, there's not going to be any drug of any type for any condition that's 100% perfect at all times. So just considering that and looking at the research well. So for historical context, I'm just actually going to move into this slide. So talking about where they came from, probably a lot of folks are, well aware of the fact that these are not new. They've been around for millennia. It dates as far back to 4000 BC, probably earlier, but there are cave paintings showing psilocybin use in North Africa. Peyote, which is mescaline, is the agent of interest that comes from the peyote cactus. It was used in the Americas dating back to 3700 BC. The traditional use of ayahuasca dates as far back to 900 BC in Peru. And then you've got, even in Europe in 1500 AD, there's been documentation that the Catholic Church considered peyote as witchcraft. So it was popular and in use at that time. So moving forward, sort of history part 2, the Prohibition era, this is really where science started to get involved with psychedelics in the West. So from the 1890s to about the 1960s, scientists were starting to isolate and manufacture psychedelics. So synthesis of new psychedelics took place. For example, MDMA, which is known as ecstasy or Molly, was synthesized in 1912. You've got LSD, which was synthesized in 38, and then ketamine in 62, originally as an anesthetic. And then isolated from these different compounds that were used traditionally in ceremonial uses for cultural, social cultural indices. You've got mescaline, ibogaine, and psilocybin. So they were able to isolate the compounds and start to study how they actually affect the brain. However, as probably this group might be well aware, recreational use and misuse resulted in lots of different regulations worldwide that made the possession, use, and even testing of these compounds illegal. And so it sort of put, there's a big gap in our historical knowledge in the scientific community from about 1970 until the early 2000s, where they just weren't allowed to be studied for the most part. One notable exception to this is ketamine, and we'll get to that in a second. All right, so history part 3 really starts around like in the early 2000s, but this timeline starts around 2017 because that's when the regulations started to change and the classification of these drugs started to change. So in 2017, you've got the FDA granting MDMA assisted psychotherapy as a breakthrough therapy status. So it was allowed to be studied in clinical trials. 2018 is when the same happened for psilocybin. And then you've got 2019 when the same happened for S-ketamine, which is a nasal version of ketamine for different indications. So this reemergence started to happen where a psychedelic started to show promise for areas of mental health and substance use where our traditional, drugs and therapies were just not working very well. You've got an increase in mental health issues and substance use in this country and others, and you have really a dearth of novel therapies that are working, and the ones that we had, that were sort of working, started to be viewed as really subpar, in particular in things like treatment-resistant depression and PTSD. There just have been almost no new breakthroughs for really decades and decades. And so you started to get this interest in these agents. So really from 2020 to the present, we've seen sort of what they're calling the psychedelic renaissance. So there's increasing acceptance of the therapeutic benefit. And there are companies now that are pursuing regulated medical indications for some of these drugs. New methods of delivery, for example, like as I said, ketamine has now sort of a nasal version. There's creams that are sometimes being used now. There are oral pills for different ones as well. And then you've got increasing clinical trials worldwide, and I'll get into some of those in just a minute. And then as of 2024, there are 2 psychedelic agents that are in phase 3 clinical trials, which is pretty exciting. So for MDMA, there's a phase 3 clinical trial for PTSD. And then for psilocybin, there's a phase 3 clinical trial currently ongoing for treatment-resistant depression. And that's happening, they're all both multi-site in lots of different places. And this is where, interestingly, we've got some regulation involved. So states have a lot of power to, determine what types of clinical trials can occur in their universities and other places. And so I believe it was Utah that just passed a law allowing for these clinical trials to occur in their health system. So Intermountain and the University of Utah are now allowing for the study of these particular ones in their system. All right, so that's the history. I just want to mention kind of what we're talking about when we talk about psychedelics. I've said ketamine, I've said MDMA. So just to reiterate what are the main ones that we're talking about. We've got on the left side here, sort of the natural ones. We've got ayahuasca, of which the psychoactive ingredient is DMT. Then you've got DMT on its own because ayahuasca has another component to it that I'll get into in a few minutes. Then you've got mescaline, which again comes from the peyote cactus. I don't know if I'm saying peyote correctly. Please correct me if I'm wrong. Okay. I was just in Arizona and everything was pronounced differently than I expected it to be. And then you've got ibogaine. We'll get into that in a little bit too. Psilocybin, most folks are aware of. That's your magic mushroom ingredient. And then on the right side, the ones that were synthesized, so they're not naturally occurring. So LSD, among them lysergic acid dithiamide, MDMA, also known as ecstasy, and then you've got ketamine, which is a really interesting drug. And I'll talk a lot about ketamine because I think it's very fascinating. Before I get into the details on those particular agents themselves and some of the recent literature that's come out and some of their therapeutic benefits, I just want to talk about how psychedelics affect the brain, because you'll hear different folks talk about mechanisms of action, and there are really 3 different levels that have to be explored scientifically. And a lot of these are just beginning to be explored, frankly, and we don't know a lot or all about any of them, to be honest, because they, again, were not really allowed to be studied well for the last several decades until recently. So there's the molecular cellular level. I'll just kind of go by what I've got here on this diagram. So on the bottom here, you see a neuron that's blue. So at the molecular cellular level, like most psychedelics exert, as I said, their effects through the serotonin 2A receptor. Now, when that happens, or when a dopamine receptor or another monoamine receptor are bound to, what you get downstream is an upregulation of something called BDNF, brain-derived neurotrophic factor, or GDNF. There are a couple different neurotrophic factors. And NF is typically a good thing. It's a huge driver of what we call neuroplasticity. I'm not going to try and bore you too much with the neuroscience of it, but generally speaking, we used to think as neuroscientists that the brain could not change after about age 26. It was like, you are set, that is what it is. It's really unchangeable. However, what we found is that there are ways in different parts of the brains where you have some plasticity. So you've got some changes that can be taking place. And plasticity happens at a number of different places. So if you look here at these little, at these dendrites, which are sort of the axon is going out from the neuron, and then it's attaching to these other neurons through these little things called dendrites. And the dendrites have synapses on them. And so the synapses can change. There are little pieces on the dendrites that can change. And what we're finding is that BDNF is usually involved in a situation where a nerve cell or a collection of cells can start to change. And that will happen on the molecular cellular level. Then when you move to the circuit level, if that's happening, what you get are that these molecular changes are actually resulting in structural changes to the neurons themselves and the ways that they're connecting to each other. You can form new connections, you can form stronger connections, you can actually break up maladaptive connections in terms of using the inflammatory system to come in and clear stuff out. That's what your glia cells do that are surrounding your neurons. And then when all of that's happening together, what you get are whole brain changes. So circuits in specific areas can change. They can become stronger, they can become weaker, but largely what you're seeing there can be the birth of new neurons in these areas. And we're seeing that with some of these agents when they're over time. And so one of the things that I find most interesting is, you'll take, if you take, for example, a selective serotonin reuptake inhibitor, an SSRI, what you get is more serotonin available in the brain. And that can bind to receptors. And that's sort of a small change that doesn't last. When you start to do things like this with neuroplasticity, you get long-term changes after a single dose of a drug. And so that's why for a lot of these agents, for example, in some of the ketamine studies, you'll have a single dose with, psychotherapy, for example, for like a 4 to 6 hour time period, and then you'll have lasting effects for months. Sometimes people say even years. And it's because you've actually rewired or recircuited the brain. Now, at the top here, before I move on, you have sort of this triangle that I think is kind of helpful just as we're thinking about this. The psychedelic experience is really important. And so you probably heard of someone having a bad trip, for example, during recreational use. Clinical use of these agents is really targeted and tailored specifically with set and setting in mind. And so the space needs to feel psychologically and physically safe. There's a lot of talk and pre-work without any agents about what the beliefs and mindset are going into a session, for example. And then the setting itself, the environment and the context need to feel very safe and need to be usually very calming. You'll see pictures of someone sort of on a couch with a blanket. They've got an eye mask on. They've got nice music going. The idea is for someone to really start to go in and start to deal with some trauma and some memories and some issues through talk therapy while on these agents in a very safe setting. And so if those things are happening, then these changes in the brain that happen while that's happening and happen afterwards during these like integration sessions that folks do, they can have very positive outcomes. Now, the same can be true of negative outcomes. If something is done in a setting that doesn't feel safe, or, if the mindset is not right, you can actually have some neuroplastic changes that can be maladaptive or negative. So I'm not saying this is a golden, ticket to changing the brain for the better. Scientists are really thinking about how to do this in a safe way that results in the best possible outcome for patients and individuals, because there have been, instances where people have usually taken these agents sort of recreationally or done things on their own and have resulted in some negative outcomes. Okay. I'm going to move on. I'm going to try and move a little bit more quickly, but if there's any paper that I ask anyone to read, it's probably this one if you're interested in addiction and the role of psychedelic science as a treatment modality. So really the take home from this whole paper, it's very long, it's a nice review. It introduces all of the different agents. It talks about the different ways that we can study them. It talks about some of the clinical trials and the history of, whether or not they work for different types of disorders. But really the take home is that they are promising for addiction treatment, different types of agents in different settings. However, we really need to do a lot more work to research and study them so that they can work better. And what I mean by that is every individual is different, every brain is different. These agents work, generally speaking, through these various mechanisms, but they work on different areas of the brain. And so if we can work with research and industry together, we can really create a precision medicine approach such that which agent and which modality will work best for a particular individual based on how long they've been using, based on what they've been on, based on their past history and trauma, based on a lot of different factors. So I found it really uplifting and helpful. This, I believe, was published just this last year. So if you want to look into it, it's a good one to read. I will just show you this one figure from this group's work based on Ralph Metzner's theorem. He was an early pioneer of psychedelic science. So the idea is that in addiction, there's a narrowed state of consciousness. So if you look over on your right side here, there's sort of baseline state of consciousness in this upper left-hand circle here. So if like the world is this 360 circle, generally speaking, our consciousness is that little V cut out. Now, in an addiction state, what we end up with, according to this theory, is a sort of narrowed state of consciousness where there's a contraction and a fixation on the object of desire, to the exclusion of really most other aspects of reality. And so the failure is the inability to take on these new information that will open awareness and sometimes things that are required for survival. And they believe that that's due to the hijacking of the brain's reward circuits. It really just narrows the focus. And so the concept with psychedelic science and medicine used as agents in addition to psychotherapy is that there's a heightened awareness that can expand that pie shaped back out again, even after it's been contracted through addiction. And so the hope is that they can actually view this using functional MRI imaging, and they've started to do that in some of the studies I've been looking at to show that brain areas that were sort of shrunk. And you can look at sort of, you could pretty easily Google, there's great fMRI imaging for cocaine users. They've got a considerable reduction in not only the volume of the brain, but different areas that light up during different activities. And that can be reopened up after the use of some of these agents in an appropriate way. All right, before I move on to the specific drugs of interest and some of the recent literature, are there any questions? Okay, I just needed a break from my mouth.
Oh, okay. Well, I'll give you one. I have a couple questions. So, one, the age. Are we doing this with minors under 18? Are we doing this with 18 to 25, or is it mostly older? I have a very close family member who's got treatment-resistant depression and went through almost all of these. But now you're talking about addiction as well. So this conversation is about those who have addiction as well as perhaps a psychiatric disorder. And I'm doing my usual Jim by doing too much at once. But so the age issue, the mental health and addiction being appropriate for this. But is it accurate that certain diagnoses like schizophrenia would not be appropriate for this kind of work, or is that an old myth as well?
I'll start with the third first. So yeah, you definitely want to be really careful with certain types of issues. I have seen some studies showing that schizophrenia, for example, in clinical settings has been worsened from some of these agents. In other studies, it shows that it can be improved. So I think specificity is really important with that one in particular. Where we've seen the most benefit is in treatment-resistant depression, in PTSD, anxiety, those types of disorders from the mental health side. On the flip, for addiction studies, in fact, they're, as far back as, early 1900s is when some of these agents were shown to be really effective for addiction. And there's a really long history of effectiveness for alcohol use disorder, for opioid disorders, cocaine, methamphetamine, lots of them. So we'll get into some of that research, but yes, both. And I will say the splashier, more newsworthy topics lately have been around treatment-resistant depression and some other mental health issues. In terms of age, I have not actually, I'll claim ignorance on that one. I don't know if we're currently testing on anyone under the age of 18. I haven't seen any of those studies. Largely, it's over the age of 18. I also think, to your point, 18 to 26 is a really interesting time frame in terms of brain development. And then over the age of 26 is another interesting time. We have been studying both. I don't know if they're teasing them apart in terms of results and outcomes. That's a really interesting point, because the plasticity of the brain is just, the younger a person is more amenable to change. That said, I know that, that a lot of these studies are in people up to, age 90, because some of these are actually being used in people with Alzheimer's and other neurodegenerative diseases of aging as well. I don't have any of those studies listed in here, but I know that there currently is a phase 2 clinical trial for Alzheimer's disease. And that's, go ahead.
Oh, sorry. I was just wondering if I could jump in real quick and add to that, add to Jim's question a little bit. My curiosity is, could you speculate, coming from your advanced understanding of brain development, whether exposure to something like this could potentially have negative downstream consequences if it was administered to younger folks, like so many of the substances that we see kind of essentially interfere with appropriate brain development?
Certainly. I will say, not having read any of the literature, potentially. There are a couple of studies, one out of the UK this year, I believe, where they actually did a qualitative study talking with people who have had negative experiences with psychedelics just from recreational use, not clinically, and some that have had issues lasting years and years after even a single exposure. And so there certainly there is a lot of literature on the fact that these can have negative effects. Clinically, it's much, much less likely, as far as I've seen, that there are going to be lasting negative effects, but they certainly do happen. And I would say I would be very cautious to use any of these in anyone under the age of 18 because of that. However, for certain indications, they could be helpful. And so I'll actually take that sort of back and do some digging, and I can kind of send it out with the slides as a follow-up. I think it's an interesting question.
Thanks. Yeah, I appreciate your perspective. It's been a curiosity. And of course, there's lots of inquiry from the public on it for some of our youth that are in kind of these really extreme states of depression. So thanks.
Yeah. I will say that, for people that have had, I think this is one of the reasons I'm so passionate about this area. Like, while it's new, and I think people are a little scratching their heads a little bit, like, what do you mean by psychedelics? It's all very confusing to me. People have preconceived notions about what that means. That said, for youth, especially like in their late teens, who are experiencing, suicide ideology and, different things that are really, there's just nothing is touching it. And there's, sort of no hope. That reminds me of sort of, the vets that, sort of go on their own down to Mexico to do ibogaine. And then Stanford did a sort of post hoc study of those people who sort of took it upon themselves to go get treated, and studied it, and found in like our Nature article that I'll talk about in a second, showed that they were 85% improved. when there's really no other treatment available to them. So I just think we have to keep our minds open. Yes, not be unsafe, not do anything that could cause more harm. I mean, that's what medicine is for, is not doing harm, essentially. But I do feel for these people who have no other avenue to turn to. And some of these are really working for some of those folks.
Thanks.
Okay. Yeah, so I'm just gonna run through a couple of the bigger substances and talk about like what they're being used for and some of the research at a high level, and then if there's interest in digging into them. Ketamine is really interesting. It was developed in '62 as an anesthetic. It's used in hospitals nationwide. Every hospital has this. You may have heard of it referred to as Special K on the streets. But it produces a rapid analgesia with altered consciousness at high doses, but at lower doses, it currently is being used in psychedelic assisted psychotherapy. And it's really the most commonly legally available therapy. There are clinics that do this all over the country. Hundreds of them have popped up over the last couple of years. There's one right here in Spokane. I think there's one in Spokane Valley. It's legal, it's safe, it's clinically safe. And the mechanism of action is, they actually consider ketamine to be sort of a dirty drug in that it has several different receptors that it binds to. And so elucidating the exact direct pathway for the effects that it has is really difficult. That said, it seems like the mechanisms for mental health and addiction treatment are its action on the NMDA glutamate receptor. So it binds, and then, like I said before, pretty much all of these increase BDNF. And so if you get more BDNF, you get more synaptic plasticity. And so that's how ketamine can have these lasting effects. There's a couple studies showing that one dose reduced anxiety and depression symptoms for up to 6 months, for example. And you'll see ketamine all over the place. You'll probably see it on your social media feed. Companies like Mindbloom have popped up. That there's another one that's in clinical trials for the nasal version. Just of note, NMDA is a major inhibitory target of alcohol. And so one of the mechanisms that's thought of for addiction treatment for this one is that upregulating NMDA, whereas some of the drugs of addiction downregulate it and create these addiction pathways, is the mechanism here. So it's known for mental health and mood disorders to be improving. It's well known to have antidepressant effects that last for weeks and months. Studies show that it's effective for PTSD, for bipolar disorder, for OCD. This paper that I just have down here with the interpretation down on the bottom says that our findings suggest that effect sizes for depression severity and response and remission were numerically greater for racemic ketamine, meaning straight up intramuscular injectable ketamine versus the nasal version, just so you're aware, because there have been some studies that are showing that ketamine is not as effective as they once thought, and it really has to do with the mode of delivery, actually, and not ketamine itself. Higher doses are more effective than lower doses. And then over on the right side here, I've got some research related to substance use and addiction. So it's been shown to effectively prolong abstinence from alcohol and heroin in detoxified alcoholics and heroin-dependent individuals, respectively. Ketamine reduced craving for and self-administration of cocaine in non-treatment seeking cocaine users. From 2018, there was a review that said that shows great promise as a treatment for various addictions, but well-controlled research is urgently needed. And there are some review articles pulling together a lot of information about addiction, and generally speaking, what it's showing is that it can be fairly effective. All right, moving on from ketamine, because ketamine is really the only legal one we've got right now, unless you're in a clinical trial. So psilocybin is your magic mushroom. It's found in several different types of mushrooms, lasts for 4 to 6 hours. Another thing when thinking about, if you're maybe designing an organization that might be considering using some of these agents as therapy for folks coming out of an inpatient setting, for example, one of the things to think about is how long does it take to do a session? And so some of these agents act for a very long period of time. Some of them are much quicker. Psilocybin's kind of in the middle here. You've got 4 to 6 hours. But if you think about needing to have someone sit with a patient who is has had one of these drugs administered to them, and their effects are going to last 4 to 6 hours. To be safe, you need to be monitored one-on-one. You need to be doing talk therapy with someone. You can think already about how expensive this becomes when you've got clinicians. We currently do 15-minute sessions with patients for most specialties, maybe an hour if you're talking about a therapist, but this gets to be very expensive when you're talking about longer sessions like this. They're very effective, but they do take a long time. So financial consideration is something I'm always thinking about, like how, reimbursement rates, et cetera. So right now, even with ketamine, you've got, I think a typical session, they're really only taking out of pocket payments. So it's really only available to folks with means, and it's about $500 for a session. And up. Okay, so back to psilocybin. The mechanisms are, again, on the serotonin receptors, leads again to that BDNF increase. You've got a lot of synaptic plasticity, changes in the dendrites. There's neuronal adaptation that happens, and this can occur for weeks and months after use. In the research, we've had some pilot studies that show effectiveness for smoking cessation. Interestingly, there are a couple of other agents that were effective for smoking cessation as well, but psilocybin most notably. It was importantly in 2018 given breakthrough therapy designation for treatment-resistant depression, and that's being studied. It and MDMA are the only ones in phase 3 clinical trials right now, which is the best sort of clinical trial. It's already been deemed safe. And now we're just talking about the efficacy compared to placebo. And there's a worldwide trial underway through Compass Pathways, and there are lots of different sites that are participating in this. So this is a good time to sort of mention that generally speaking, what these sessions look like is there's multiple prep sessions ahead of the actual session with the agent. Where a lead or an assistant therapist will do some sessions just to talk through with the patient, some of their goals, what they're trying to achieve. They might have them sort of journal or write, their history out so that they can really come back to it during the session itself. Then there's the dosing session itself for around 8 hours with the accompanying talk therapy. And then there's follow-up, what they call integration sessions, to consolidate the insights from the experience. And what they found when comparing, actually, they've done some studies comparing with and without these follow-up sessions, is that they're less, the actual session itself with the agent is less effective long-term without these integration sessions. So what you get sort of, what you're trying to do is like really build on these new circuits and pathways that are positive, and moving away from the addictive circuits or the circuits that are really solidified with the mental health disorders and these new pathways, and then they're consolidating these more positive pathways. All right, moving on to MDMA. This is known as ecstasy or Molly. It's considered an empathogen. This one I think is fascinating. Some folks say this isn't even a psychedelic. But it blocks monoamine reuptake transmitters. It is an agonist on some serotonin receptors. But importantly, this one facilitates an enormous release of oxytocin, which is known to increase empathy and closeness and decreases the stress response and social anxiety. What I've heard from clinicians that are trained to do MDMA-assisted psychotherapy is that essentially what it allows someone to do is to access traumatic past events in their subconsciousness or in their consciousness, in their memory banks, from an empathetic perspective. So they feel safer going into those events. So for someone with PTSD, this is extremely important, being able to access those memories. It's been said that they sort of naturally feel less guilt over events that have happened, both for themselves and for anyone else involved in the situation. So I found that to be really interesting. There are a couple others that have an increase in oxytocin, but that one's really important. And as I mentioned before, MDMA is currently in a phase 3 clinical trial for moderate to severe PTSD. I've been told that there are over 30,000 vets on the wait list for this trial. So word got around. Some of them are going to other countries to get it instead, but we don't have a lot of really great therapies and treatments for severe PTSD, and this one seems to be working really well. All right, Sarah is really probably the better expert on ibogaine, the other Sarah. but I'll do my best. So ibogaine was discovered by the West. It's an African plant. In 1864, we isolated it. I say we, somebody isolated it in 1901. It was actually patented originally as an interrupter of narcotic addiction in 1985. So the subjective experience of this, I found interesting because it lasts a really long time. Again, speaking about like needing to really be with somebody and monitor them for this long. So the first phase is sort of, they call it a waking dream, is 4 to 8 hours long. And then after that, for up to 20 hours is an evaluative, emotionally neutral, sort of reflective time period. It's a great time to do talk therapy, for them to do some writing, to be thinking. These are often used ceremonially. And then up to 72 hours after ingestion, there's heightened awareness and some sleep problems that were experienced. I've been told, and some of the research shows, that ibogaine is not particularly pleasant. It's not something that folks are like willingly and wanting to go back to experience again, which I think is actually useful and interesting. It has a really complex pharmacology. It binds to lots of different receptors: opioid, serotonin, dopamine, glutamate, stigma. It's got anti-inflammatory effects, but it does, as many others, elevate those neurotrophic factors, GDNF and BDNF, in key areas of the brain that can disrupt addiction pathways. And so basically what I've been telling a lot of folks that I think just makes it easier to think about is, addiction pathways get really strong circuits solidified. It's that sort of like narrowing of consciousness so that their focus is primarily on, the drug of interest. Those pathways get really solid. Think of them as like turning to wood almost. What's really interesting about ibogaine, it can go in and disrupt these physically, those circuits, from the molecular level up through the circuit level, up to the whole brain level, as I mentioned in the previous slide. I'm not going to go through this in detail, but ibogaine actually, as I said, it acts on lots of different receptors and has lots of different effects. And they believe that the mechanisms of action for different addiction pathways are different. So for example, alcohol and nicotine have different receptor pathways than other drugs like opiates, for example. But it does have a hallucinatory effect, just like the others, because of its acting on that serotonin 2A receptor. But it's these other receptor subtypes that it's binding to that we believe are involved in addiction. So just real quick on some of the studies. There are lots of studies, including a couple of randomized control trials indicating effectiveness for substance use. The problem with ibogaine is that there are well-known effects on cardiac cells, especially in folks who have previous cardiac issues. So it lengthens the QT interval and can cause cardiac arrhythmias and even death when used. However, a recent study showed that when you combine the ingestion of ibogaine with magnesium, you can ameliorate those effects and protect the heart. So hopefully, and that just came out in late 23, I think early 2024. That study. And so hopefully there's a little bit more willingness in the research community to study ibogaine more widely. All right, I'm going to move on. I've got two more. LSD is probably pretty well known, lysergic acid dithiamide. It was synthesized in the lab. Primarily against serotonin agonist. This one's pretty strong. And there's actually a lot of research on this for therapy for alcoholism and anxiety that have been really effective. There's also some research showing that microdosing LSD, as well as psilocybin, to be honest, can be effective for the treatment of anxiety and depression. So at doses that are sub-hallucinatory, you actually wouldn't even necessarily know that it's on board, but they have studied that versus placebo in some of these studies and found that it's effective. All right, the last one is DMT. I find this one really fascinating. Dimethyltryptamine, the amino acid tryptophan is involved in the pathway that creates this. So actually, this is the one that's naturally occurring in the body. So it's expressed in our brain cells and in different parts of our bodies at different times, especially in neurodevelopment. They don't quite know what it's for or what it does. naturally occurring, but at certain doses, it can be used as a psychedelic. So it acts on lots of different serotonin receptors. It's a sigma-1 agonist, which is anti-inflammatory. It's extremely important. The TARS, of course, it increases BDNF. And there's a phase 2A clinical trial for major depressive disorder that's ongoing with really positive early data as of, I believe, early this quarter. So they are using it for that. Now, DMT is the active ingredient in ayahuasca. If anyone's ever heard of ayahuasca, folks like to do ayahuasca retreats down in South America. This is really just DMT that you can drink. DMT usually gets broken down by something called monoamine oxidase. The reason that ayahuasca works is because the DMT is taken with another agent called beta-carboline alkaloids, harmonine, tetrahydroharmonine, and harmaline, which is an MAOI. So monoamine oxidase inhibitor. So what it does is it inhibits the thing that breaks DMT down. And so you can ingest it. It won't get broken down immediately and actually can get into the bloodstream and have its effects. So it's a way to drink it and make it work. Otherwise, DMT has to be injected. What I like about DMT is that it's very quick acting and only lasts for about 1 to 2 hours, sometimes even less. So if you think clinically about having a shorter time period to work in, that's maybe not great for some instances, but in others, in terms of just needing to sort of, have sort of a quick acting substance that can get out pretty quickly, this one works really well when it's injected. Ayahuasca lasts a pretty long time. It's been shown to have rapid antidepressant effects. And a systemic review indicated that there was therapeutic benefit for substance use disorders. But, the thing about ayahuasca is that there aren't clinical trials or clinical use for this. It's typically been ceremonially used. And so a lot of those studies are really qualitative studies, talking to individuals and measuring their alcohol use or their other drug use before and after taking these agents, or over time if they've been using it regularly. And what they find is a really significant reduction in alcohol use and other drug use for people that regularly take ayahuasca. I'm not going to go through these, but these are other clinical trials just from Q1 of 2024 for different psychedelics. They're considering it to be in the future $100 billion industry as we move into a world in which FDA approval might happen for some of these drugs for different indications. And so I'll just really briefly talk about some challenges and considerations. Again, as I mentioned before, there are adverse events. There are some papers that specifically talk about what some of those are, and they really need to be, I think, explored more so that some of these therapies that we are introducing into the market or into clinical trials for a lot of people, if we can sort of start to think about the science of developing them to reduce the likelihood of adverse events, that's what we need to be thinking about. Regulatory environment, I would like to see this not get conflated with recreational use. As I said before, I think that the two things are very different and separate and should maintain that separateness so that we don't end up in a situation like we did with the cannabis industry. There's a lot of stigma still about psychedelics and misinformation based on the war on drugs. We're going to have to overcome a lot of those things in order to allow these things to be available and used by people with these types of issues, of which I believe 60% or more of our country is suffering from some sort of mental health issue or addiction issue. And then recreational use, as I said, I don't like to touch that one. I don't think that it's, I claim Switzerland on that one. But again, I just think that we need to separate the conversation and only be talking about these things for appropriate clinical use. All right. So just so you're aware, people are working on FDA reclassification for MDMA and psilocybin specifically. Cannabis is on its way. It's not, that one's not a psychedelic, but I think that's going to pave the way for some of these other things being descheduled. And MDMA is probably the furthest along that path for use for PTSD specifically. And then there's state-based legalization and clinical use allowance that's happening in different places. And I think that we can push for some of that even in Washington in the near future. All right, that's all I have. So if there's any questions, I'd love to answer.
Yeah, thanks. I did have a question. Do you know, or do you foresee Salvia divinorum being researched at all for medical or therapeutic purposes? Or do you think that one might just be its own separate thing compared to the serotonin receptor psychedelics?
Which one?
Salvia divinorum.
Oh, I haven't looked into that one very much. So I do think that I've heard a little bit. So yes, I really think that this whole subject is going to be sort of exploding in the next 10, 15 years. So I
Oh,
would,
certainly.
yeah, I would not be surprised if it hits, more mainstream, but I think right now we don't understand a lot about the serotonin. So
Yeah. Cool, thanks.
yeah.
MJ, it looks like you have your hand up, and then we have a couple in the chat box that I'd like to go to afterwards.
Yeah, so my question would be, for like the people that can't afford it, what should they do? Like, because everything's like pay out of pocket. Like, if like the recreational route doesn't go, like, what are these people, like, what do they do? Like, what can they do?
Yeah, I think I would never advise anyone to sort of, go to like a black market or underground or anything. I know that a lot of folks are doing that. They're going to other countries to seek treatment. They're going to different shaman that are operating in the United States to chat with them about where they can receive safe care, for example. I just think, right now we're going to have to wait until some of these things get approved for clinical use that has a reimbursement strategy associated with it. It just might be a while, unfortunately.
Okay.
Can I add a little bit of info? I recently have been involved with some folks in Oregon. I'm sorry. Because Oregon is one of the states that decriminalized. Some of the clinics that are set up over there are doing sliding scales, and they're above ground because of Oregon's change in legislation. So although not accessible to everybody, I do know that some of them are doing that for folks who have limited resources.
Yeah, and I've heard of a couple other places where it's been, in the Colorado areas, around Denver, there are some clinics that are doing that work as well, and then a couple of different counties in California, as far as I know. There are also, and this is very different, but there are psychedelic churches that have popped up now in a number of places, where things like ayahuasca are taken, and I hesitate, there are a lot of people that are actually going to those places to seek this kind of like treatment, if you will, in addition to recreational use or ceremonial use. I certainly wouldn't recommend that, but that is a place where people are going because of really the price factor and the availability.
I'm just going to jump in real quick because we're actually going to change because we want to keep the questions coming. So instead of a wellness break, we're going to just end a little bit early. So we have some discussion here that we can continue on. And Jane, I believe you had a great question in the chat that I wanted to bring to attention. Are you still on here? And if not, Sarah, do you want to look in it's talking about, just has to do with adolescence. It's pretty specific. My worries about adolescents having a first break, wow, I'm not, yeah, with psychedelic use, if you want to touch on that.
Yeah, I think, again, I'm not a physician, and I'm certainly not an adolescent physician, so I can't speak to that from a clinical perspective. However, I can look into the research on it to see if there's any association between younger use of psychedelics and a psychotic break. I do think that, again, just to speak to that triangle that I had in one of those slides, like the set and setting and the agent in particular of use is like, I cannot stress the importance of that enough in terms of the outcomes and the effect that it has on a brain. And so a lot of the information that we might have about some of those maladaptive events or outcomes happening even in adolescence may be because of the set and setting in which a drug was used. And so I think, frankly, even the research that we have might be anecdotal or qualitative and maybe not the same as what we would see in a clinical setting. So I'm not, I wouldn't divorce those two, but even I can sort of anticipate that I would find something showing that there's an association. However, we probably don't know, if it hasn't been clinically studied, what the effects would be for younger people in a clinical setting.
Great. And then Sam and then Jim.
Hi, Sarah. So I work for an addiction treatment center, and so this is all very, very exciting to me. I'm just wondering if there's a connection between the efficacy of each of these treatments and the number of sessions where each is administered, or if it's like there's a critical number of sessions and then like you see prolonged abstinence based on that.
Right. So what for the most part, a lot of the research that I've been looking at shows the efficacy with one treatment.
Oh, wow.
And what they're measuring is the prolonged effects, 1 day, 1 month, 6 months out from a single treatment. I'd have to do a little bit of digging to see if there was a dose dependent response for those types of studies I've been looking at, for example, ketamine and psilocybin. Actually, 25 milligrams, for example, was better than 1 versus I think even 15. So they have different doses that they've been trying, but it's single session. But I'd have to look into it, whether it requires, what I've been told is that some folks require like every 6 months sort of a resesh for certain agents, but I'm not sure about all of them.
Well, thank you.
Mm-hmm. That was one of the things that really shocked me. I was like, one treatment? Like, it just seems like, and then, looking at the data going, yeah, one treatment for a lot of these things.
Yeah, because I think some of the argument you're going to come up against from experts in the addiction field is, oh, well, you're just trading one for another. But after one session, having these results is awesome.
Yeah, we're hopeful.
Jim, you're up.
Thank you. And I have a couple, but please get other folks in and all that. Thank you so much, Dr. Sarah. This is really, really tremendous information. So one of my questions is, ketamine is the one that's legal now, and there's others who are moving forward. What can you say, if anything, about the appetite of insurance companies and Medicare to start helping, to MJ's point about helping pay for this and seeing the long view that they might actually save money if they invest in this versus, oh, it's not covered kind of thing. I just wonder if there's anything happening there. Any thoughts?
Well, so it all hinges on FDA approval because they can't pay for it unless it's approved. So we're getting there with MDMA, hopefully with psilocybin for particular indications. Here's what I think is going to happen, because I sort of see things in a system manner. So you've got a lot of biotech companies that are interested in this. Like I said, it's going to be $100 billion industry if things continue on the trajectory that we're seeing right now. There aren't a lot of effective treatments for mental health and substance use issues, frankly. And so it's going to be a big industry. Those companies, as they're doing their work to, refine and better create agents that will work really well for people, and we get precision medicine on board, those groups are going to start pushing on insurance companies to reimburse, and for our agencies in probably federal and state government to approve, uses for particular issues. So with all of those things right now, I think we're sort of seeing this like swirling happening. Where a lot of it's, not legal and not allowed, but the research is pretty clear that there's something here. And so, so not yet, but I think we're pretty close, frankly. A lot of huge dominoes have to fall in order for us to get there, but I think that we're pretty close.
Jim, I'm going to interrupt you just for a minute because I know you have a couple more, but we have a couple comments in here. Patty, she said, what are some of the stigma issues you've been coming up against? And what are your ideas about effective responses to those?
Yeah, I mean, so my effective response to stigma in terms of this particular area of interest, which has been an interest of mine for just a couple of years now, is data. Like really strong, solid data is the answer to a lot of the questions that I get about, but is it safe? But is it effective? Like, but, and then, really showing, there are lots of videos that you can show people, that are like explain exactly what a session looks like. People explaining what it felt like for them, that sort of thing has really helped. But really just battling the preconceived notions that people have about, psychedelics, about that this isn't about hippie culture, this isn't about recreational, use, because there were and still are some really negative experiences that can have lasting, even years long traumatic effects for people using these agents. Like I will not shy away from that whatsoever. But what we've seen in all of our clinical trial data is a really clear safety profile when they're used in a setting that is clinical and safe and appropriate, and medically oriented. So again, if I just separate those two things out, sort of the negative, and there are even clinical negative experiences that people have, but they're vastly fewer than when folks take these sort of into their own hands, if you will.
Jim, do you want me to come back to you unless somebody else wants to raise their hand? And then we'll go back to the comments. Jim, any other questions? You said you had a couple.
Yeah, so about 20 years ago, we moved away from psychotherapy and insight oriented in terms of a theoretical framework. I don't know if we totally moved away, but we seem to be moving towards more of a cognitive behavioral framework in talk therapy. And I wonder if there's any agreement, or when you have your integration sessions, is there sort of an agreement or discussion around what is the theoretical framework for those integration sessions that best match the drug that's being provided and given?
So yes, actually, I will point you back to, because I can probably share the slides around, or I'll send them to Sarah so that you can have the information. That review article that I was talking about goes through a lot of those different. So I leave a lot of that to the systems neuroscientists, if you can believe it. I certainly am not an expert in all that systems work. I was a molecular neuroscientist when I studied, and so that part of all of it is less of my area of expertise, but the review article does a really nice job of walking through the different areas. And like you said, different agents require different types of follow-up, and have different sort of theories and frameworks that you want to use to, best exploit the positive outcomes and benefits of whatever that particular agent was. So I won't say more than that because I don't want to get myself into trouble where I'll be very clear where my knowledge starts and stops. And that's one of the areas that I don't have a lot of expertise in.
No, I appreciate it. I'll read the article. The last question is, any movement toward viewing eating disorders as benefiting from some of this?
I don't know. That is a great question. I'd have to look into it. I would be surprised if not, however, based on the fact that a lot of the same pathways and circuits are involved in the pathogenesis of body dysmorphia and some other issues. Yeah. I think that honestly, we're just starting to crack what these things can be really beneficial for. Just the fact that we're now open to the fact that you can change your brain in a real meaningful way as you age, and with some of these issues that we thought were sort of chronic illnesses. They may still be chronic illnesses, but I think that we now have access to some therapies that can really provide a lot of relief for people that have absolutely nowhere else to turn.
All right. With that, are there any other, Johnny, are you about to say something? Because I kind of see your screen that just popped up.
No, I'm not.
Oh, I think you kind of are
Okay.
cutting it out.
That's okay.
Okay. Any other questions before we move on and close this amazing session with Sarah. I'm going to give everybody one more moment. All right. Well, with that, we're going to keep going on. But Sarah, there's lots of comments in the chat just thanking you, people with lived experience, system partners. So I just want to, again, profoundly thank you for this. It was informative and exactly what I wanted for the group. So thank you for your time.
Of course. All right. So I can pop off.
You're good to go.
All right. Thanks, everyone.
Bye.